our first speaker is Dr. Femina Hashim, and her topic is it retinal detachment or is there something hiding? We have kept the case presentations to be short. There is some discussion as well, but after that I hope you will be asking doubts and we can get the discussion going.
A very warm good morning to one and all. Let's start with the first case of our IC. Is it retinal detachment or is there something hiding? So this is a 56-year-old male who came with a complaints of sudden onset defective vision in the right eye for around 2 weeks. His best corrected visual acuity was right eye counting fingers 3 meter, and the fellow eye was absolutely normal with 6 and 6. The anterior segment examination was unremarkable, and this was the fundus finding of the right eye. And you can clearly see the fundus picture looks like a chronic retinal detachment, and you can see the inferior gliotic membranes with a serous retinal detachment or the elevated retina. And you can clearly see some peripheral retinal degenerations also. And this was the left eye picture. The left eye was absolutely normal except some retinal degenerations in the periphery. So we did an OCT of this patient. The OCT scan passing through the fovea as well as the inferior retina, and it shows a serous retinal detachment involving the macula as well as multiple pigment epithelial detachment, and you can clearly see it's a pachychoroid spectrum. So initially we thought it is a chronic retinal detachment, but once on diagnosis you are finding like it is very difficult. Why? Because it's not a straightforward retinal detachment. So at this point, we were something like it's a chronic retinal detachment mainly due to an inflammatory pathology, or once you see the pachychoroid spectrum, are you dealing with a chronic CSCR, or is it a PCV, or is it a peripheral exudative hemorrhagic chorioretinopathy? So once in doubt, you can just order an angiogram, and this was the angiogram report. So you can clearly see some multiple RP leak points, but these were less active and persistent. So once you see some multiple RP leak points, your first diagnosis will be CSCR. But in CSCR, you are seeing much more active leak, but in this case, it was very less active. There was patchy hyperfluorescence due to RP atrophy and areas of subretinal staining corresponding to the chronic serous retinal detachment. Even after the FA-ICG, we are not sure about the diagnosis. Why? Because you are not ruling out a PCV, not ruling out a CSCR. So we done an OCT, the wide field OCT of the RCT angiography of the right eye, which was clearly showing a clear vascular network in the avascular layer. So let's wind up. You are seeing a 50 to 70-year-old patient with chronic SRF without any drusen in the fundus, and in the OCT you are seeing a pachychoroid phenotype and vascular network in the OCT angiography. You are dealing with none other than pachychoroid neovasculopathy. So the patient received an intravitreal anti-VEGF after getting a diagnosis. So this was the post-Pegenax 2 weeks. You can clearly see how beautifully the serous retinal detachment get attached, and the vision improved to 6, 18, and 12 from counting fingers 3 meter. And this is the post-Pegenax at 1 month. The vision is 6, 9, and 6 with a good anatomical recovery, and even at 3 months, the anatomical recovery is stabilizing, and the patient is under our follow-up. So pachychoroid neovasculopathy, it's a distinct form of type 1 MNV, and it also includes CSCR and PCV. It is distinct from typical NAMD. So pachychoroidopathy is a dynamic disease spectrum which can have varied disease manifestations at different points of time, performing multimodal imaging forms the crux in diagnosis and optimal management. Thank you.
Is the pachychoroid spectrum, and sometimes it is very difficult to, especially in the chronic cases, it is very difficult to distinguish from rhegmatogenous retinal detachment when it is inferior. So you have to look very carefully at the periphery for breaks, and if you are not seeing a break and it looks very atypical, then you must think in terms of especially if you have other changes like a thickened choroid or multiple PEDs, which may be shallow or small multiple PEDs, then it should, and look at the other eye also, because a pachychoroid spectrum patient usually will have choroidal thickening in the other eye also. That will also give you a clue. And if you don't have access to an opta, it is even a simple normal fluorescein angiogram can give you a good idea of whether you're looking at an exudative serous type of detachment or you're looking at a rhegmatogenous detachment. So It is an important investigation to be done before you take up the patient for surgery. Does anybody have I think straightforward CSR, I don't think we need to discuss because what about chronic CSR? Does anybody have any doubts regarding chronic CSR? What to be done, how to... Can you give us some tips on how to distinguish chronic CSR? Because most of the time chronic CSR patients present with decreased vision, which is fairly unexplained on examining the retina. You may not get much findings. So what are the tests that you will do that tell us that this patient has chronic
Mainly
CSR?
we can do an OCT and as well as the AF. Because of the chronic, you can see the RP track pattern in the autofluorescence. And mainly, this one also you can proceed with angiogram FA-ICG also to know the leak points, but it won't be that much active as you are seen in an acute case. That will be the problem.
Yes, so the activity per se may not be there when you do. You will just see window defects, extensive window defects on your fluorescent angiogram. But for a chronic CSR diagnosis, you don't need a fluorescent angiogram. The simple test that will tell you that this is chronic CSR is an AF. And if you combine it with the OCT, you can clearly know whether there is fluid or not. So if there's no fluid and you're just getting AF defects and you have a very decreased vision, you can explain the prognosis to the patient that there really isn't much to do because the RP has become completely atrophic. But if there is fluid, you can think of the treatments that we give for chronic CSR, which would be then meaning that you have to go ahead with a fluorescent angiogram, because if there is a leak, if you are not seeing just window defects and you are seeing a leakage, whichever pattern of leakage or multiple areas of leakage, you can consider a CSR laser to that area so that the leakage is stopped.
If this, like in this case, you said the patient's vision was fixed with the other eye and there was no refractive error, right? If he was a high myope in this case, in the first OCT which you showed me, if I had not known the history, maybe I would have also considered myopic maculopathy as a DD. So how will I differentiate if the patient is myopic?
But myopic maculopathy, all the changes in that case are inferior. You can see the gliotic membranes, you can see that there's fluid inferior also. Myopic maculopathy, generally what we call dome-shaped maculopathy, is usually just limited to the macular area and usually intact, retinal layers will be intact unless it has been there for a long time and it has caused intraretinal changes also. And you will see a very staphylomatous fundus and very limited to the macular area.
And in such a case, this whatever management we did will not help, right?
No, in dome-shaped maculopathy, generally we don't have much active management to do.